Good morning, everyone, and thank you for joining us. My name is David Schwartz. I'm the Vice President of Public Policy and Federal Affairs here at CareFirst Blue Cross Blue Shield. I'm very pleased to welcome you to today's discussion, which is called From Passage to Practice, the ACA at 16 and What Comes Next. I think for a lot of us, it's hard to believe that it's been 16 years since what we all know now as the ACA, or Affordable Care Act, was signed into law back on March 23rd, 2010. So Monday is the official anniversary. Today, we will reflect on how the ACA changed the insurance experience for consumers, the impact it has had across insurance markets, including the commercial market, Medicaid and Medicare, and some of the challenges that the ACA has faced and continues to face as we pursue greater consumer affordability and choice. The primary goal of the ACA was to increase access to health insurance coverage. This was made possible in large part by the expansion of Medicaid to cover what are known as childless adults at or below 138% of the federal poverty level, as well as the establishment of health insurance exchanges or marketplaces, which provided access to comprehensive health insurance for individuals and families buying through either healthcare.gov or through a state-based exchange. The ACA has reduced the uninsured rate pretty significantly. Prior to the passage of the law, the uninsured rate was somewhere around 15% and ticking upwards. And back in 2023, the uninsured rate reached its lowest rate ever at 7.7%. And while this is certainly a noteworthy accomplishment, we have to acknowledge that many people still lack coverage, especially if their state did not expand Medicaid or if their eligibility for the tax credits that are available on the individual market through exchanges did not make coverage affordable enough for them to buy. Additionally, recent policy changes, including some in the One Big Beautiful Bill Act or HR 1 from last year, will continue to change the experience for consumers, notably the Medicaid expansion population and individuals and families who buy coverage on exchanges. At the end of last year, we also saw the expiration of the enhanced advanced premium tax credits, which is estimated to significantly increase premiums and also increase the number of uninsured individuals by potentially around 4 million people over the next 7 or 8 years. At CareFirst, we are committed to innovation, thoughtful partnership, and advocacy on behalf of the members we are honored to serve. We believe it is important to reflect on the transformative impacts of legislation like the ACA while continuing to think through solutions to continually improve the consumer experience, affordability, and access. It's also why we're thrilled to bring together this panel of experts today that has a very rich legislative, regulatory, and industry expertise set as we mark the 16th anniversary. Personally, I'm lucky enough to have known and worked with today's panelists for many years. And while we will acknowledge the milestone today, we also want to assess where we are on affordability and access and what we can do to continue to improve consumer experience in the future. I hope today's discussion sparks ideas, questions, and reflections that move us toward a more accessible healthcare system for everyone. We may have time for very brief Q&A at the end, so folks in the audience, please feel free to use the chat feature to lodge any questions, and we'll get them over to the panelists. And with that, I will shut up, turn over this session, to our moderator, CareFirst's own Mike Rapach, our Senior Vice President of Government Programs. Mike?
Thank you, David, and good morning, everyone. I'm happy to be here this morning with our excellent group of panelists to discuss the history and the future of the ACA. My responsibilities at CareFirst and government programs include Medicaid, Medicare, and Medicare Advantage, and also our individual ACA businesses. That kind of reflects the broad scope of many of the things impacted by the law that we'll be discussing today. We'll be discussing a lot of the successes associated with the ACA to date, how it's transformed the consumer experience, the affordability and the access changes that remain, and how to best ensure some of the consumer protections that are well needed continue going forward. The ACA has been a very complex topic since its passage. And we didn't convene this panel just for the sake of patting ourselves on the back and saying how wonderful it is. We really wanted to reflect and have an honest dialogue about where we've been, where we are, and where we want to go to preserve access to coverage for enrollees. We are here to have a real conversation and kind of talk through the good and the bad, where we are, and what this will mean going forward. So let's jump in. Today we'll hear from three panelists: Ellen Montz, Managing Director of Manatt Health; Randy Pate, Founder, Randolph Pate Advisors; and Andy Chasin, Vice President of Federal Policy and Advocacy at Blue Shield of California. So I'll start off with some brief introductions. If you can all join me on camera, we'll go ahead and jump in. Ellen, why don't you introduce yourself first?
Hi, good morning, everyone. Ellen Montz. As Mike mentioned, I'm currently a managing director at Manatt Health, but formerly was the director of CaSIO and the Affordable Care Act marketplaces across the country under the Biden administration. And I was also formerly the chief deputy of Virginia's Medicaid program, and even before that, in what we will talk about today at depth here, with the White House and Department of Health and Human Services during the Obama administration.
Thank you, Ellen. Randy, why don't we go to you next?
Sure. Hey, my name is Randy Pate. Like Ellen, I was also a former director of CaSIO. I was in the first Trump administration. And since then, I've started my own solo consulting practice. I've been doing that about 5 years, working with a range of clients. Prior to that, I was with, I have a really interesting history with ACA coming from the Republican perspective, but prior to the Trump administration, I was over at HCSC for about 6 years when all the regs and the initial rulemaking and all of that happened and the rollout. And then I was over at actually at the last 2 years in HHS, the George W. Bush administration, kind of right before the ACA. So I have an interesting history with this law, but great to be here today.
Thank you, Randy. And Andy.
Great. Thank you, Mike, for having us. So I was actually, David was talking about the 16th anniversary. I was on the Senate floor with David when it passed. I was the Republican Policy Counsel in the Senate. So handled all the policy issues during the debate over the Affordable Care Act, and then moved to California, where I then implemented the ACA for Blue Shield and helped stand up that market. And then moved back to DC, where I run federal policy and advocacy for Blue Shield. And want to say that I lobbied Ellen and Randy while they were both CaSIO directors, and just want to thank them for their service. They both have very different perspectives, but came to public service with really kind of the best of what we would hope for people in their positions, and always really put consumers and affordability first. So really delighted to be on a panel with both of them.
Thank you all for the introductions. So let's go ahead and jump in. So March 2010, I was working for one of the large national insurers, and we were watching a debate and how everything was coming together for the ACA, and all trying to figure out what was going on, what was going to happen, and where we went. All of you were kind of doing your various roles as you described with this as well. And so when we look at it, 2014 is kind of where we say, okay, the exchanges started, we got into really selling insurance under this new format, but a lot of other things kind of kicked in well before that. We look at some of the things that changed in the commercial insurance, the discrimination on pre-existing conditions, a massive change to how insurance worked in America. Change and banning on annual and lifetime limits on benefits, restricting the amount of out-of-pocket costs individuals and families incur, requiring health plans to cover preventative health services without cost sharing, and young adults until the age of 26. Now, this is kind of now table stakes for us in the industry, just kind of the nature of what we work within, how we plan and build out what we sell and offer to consumers around the country. So, Andy, why don't we start with you? What was your perspective on all of that? How did plans navigate changing that? And all of you feel free to jump in as we go along. Just how did that change the experience with healthcare and insurance in America?
Thank you. It was really a paradigm shift for insurers, and particularly in this market. And I think we need to remember what it was like before the Affordable Care Act passed. So, if you were an employer, coverage, was enhanced under the Affordable Care Act with certain things. But if you didn't have employer-based coverage, it was really the Wild West. So we would have, as an insurer, you would have these, 10 to 50-page questionnaires that you would have to fill out that had every doctor visit, everything that every cough, every sneeze, you would have to list, and you would be, underwritten. So basically, determined if you could be covered. So you have to be perfectly healthy in order to get that coverage. And at some points you could get challenged for that coverage, even if you did get it through rescissions. The premiums were going up at 30-40% a year in California where I was. So just a really difficult market for consumers, and meant it that you really, if you had an opportunity to be with an employer and get coverage, there was job lock. Like you really needed to stay with an employer for that purpose. And so the ACA really changed all of those rules, provided uh, a guaranteed issue, make sure that regardless of pre-existing condition, that you would have access to health coverage, had tax credits to make sure that people who couldn't afford it were able to access it. Lifetime limits were prohibited, and so just a whole suite of reforms that completely changed the market. And we'll probably get into this, but I mean, early on, it was a lot to digest, a lot of reforms for us all to deal with. States were doing it in different ways. And it was a bumpy beginning, but I think the results are a really mature market that's critical for consumers.
Thank you. Ellen, what is your perspective on that as you look at how all of those things kind of came together, the bumpy ride along the way, and then kind of where we are now and how that's reflecting in the current marketplace?
Yeah, I think, Andy mentioned just the incredible paradigm shift, right? That occurred in the market, where you go from an incredibly underwritten product. I remember when I first came to DC, one of my jobs was going through some of those questionnaires and like circling and finding things that were, we would consider today incredibly absurd, that could be underwritten or you could be denied insurance. And so I think it's like you cannot understate just the incredible shift that occurred, both beginning in 2010 and then further on in 2014. I do think one of maybe the undervalued aspects of the kind of provisions and the consumer protections included in the Affordable Care Act are the exchanges themselves. Right, the kind of concept and the capability for a consumer to come to the federal marketplace, if they have a state-based marketplace, to come and be assured that each one of the plans that they are looking at offers a level of protection that they can count on. Right, I think that is an incredibly important component of the ACA. I think the benefits of that kind of shopping experience have yet to be fully realized for folks, but I do think it's one of the undervalued kind of ultimate consumer protections for folks of the ACA that I do worry about as kind of the market progresses and we move to kind of more dissipated models. I worry about that assurance that consumers can have in the ability to come to kind of one place and know that the plan that they select is going to offer those incredibly important protections.
Thank you. I would agree with you. I think the certainty of the quality of the purchase and what you're buying into and having a good sense of what's there is a very different world than we lived in prior to the passage of the ACA. Randy, how about your perspective in all of this?
Yeah, I think all that's super interesting. I mean, so Ellen, to your point, oddly enough, I was a health policy fellow, had just gotten out of grad school when Romney Care was going through. And so I was at the Heritage Foundation, and they were actually very involved with the establishment of the exchange. And, they were talking not only to Massachusetts, but I think Maryland and Utah. There were a number of states that were headed in that direction back then. So, I do really think that is a great innovation for this market, for the individual market, where you got multiple insurance companies coming in and playing, one-stop shop where you can go see, just like we take for granted with Amazon and, Travelocity today. So I do think, and that's been a big focus of my career leaving, after leaving CMS, was how to encourage more states to establish their own exchange, how to, get more innovation to make these exchanges work better for people, be able to work for all the different types of people that come to the market. And so that is a huge, innovation, I think, that has come out of this law. The other pieces, obviously were big changes for the individual market, some of which, were pretty settled and from the group, the large group side, with HIPAA. But, I think bringing it to the individual market, most of those things you ticked off, I think, are fairly, you're not hearing a lot of controversy around those today. So I think they have become fixtures, like you said. Now, I think there's ways they could be improved. There's ways we could, tweak them to make them work better. And, maybe we'll get into that. But, I think all of those things are pretty big achievements of this law.
Thanks, Randy. I'm actually going to follow up a little bit there. So since you mentioned it, we'll go a little bit off script. So what are some of your thoughts on ways that could change? Since you kind of covered it, I think it'd be good to just dive in a little bit.
Yeah, I think back to, when the law was originally passed, obviously you had the individual mandate that sort of penalized people who didn't purchase, and, that was obviously very unpopular. That got repealed. So then, some states have gone that direction to sort of reimpose penalties. But so my big thing, or one of my big things, is how do we make this product attractive? We got down to, a pretty low uninsured rate, kind of coming out of the pandemic with enhanced subsidies. But how do we make these products attractive to people who, even in that environment, there were a lot of people who just sort of said, nah, I don't really want to buy this. So how can we get those people into the market? And I think you have to make it really affordable for them. You have to give them benefits that they want, that they're going to use. And, I think those are challenges. And then also, I think, how they shop for coverage, right? I think it has to be very, very easy and basically, very turnkey for them. So, yeah, I don't think we've figured all that out yet, but I think those are areas that I'm really interested in.
Excellent. I definitely agree with you on a lot of those things of the shopping experience, especially of helping people understand what they're actually getting into, and the nuances and complexities of it are a big piece. Ellen and Andy, anything you want to add on to that one? Okay. Oh, Andy, please go ahead.
I agree with Randy, and maybe we'll get into this later, but I think there is this, this tension on affordability, and the ACA in many ways has become a proxy battle for the rest of the market. And so I do think that the Affordable Care Act, we see premiums rising, fairly consistently. And there's a lot of talk about like what needs to change in that market to make it more affordable. But we see it in the rest of markets too. And so I do think that we need a broader aperture on some of those challenges. And the ACA, I think, it's a overwhelming focus, where I think the issues in healthcare generally, are fairly broad.
Ellen, any other thoughts?
Totally agree. I don't think you can go 30 seconds in this business without hearing the word affordability. So, I think, look, this is consistent across all markets. I also think, I agree with Randy. There are, we want a market that has products that are, that meet everybody's needs, right? I think I will say that kind of the one of the things I didn't mention before, but I do think is actually like the keystone of, kind of the consumer protections and the ACA market is the single risk pool. And I think that you can have product differentiation within a single risk pool without kind of carving out kind of folks from the market itself. And so these are some of the dynamics that I think we're facing today in the name of affordability. And I think we'll likely get into some of this discussion today. But I do think this is really what is kind of driving a look at not only this market but all markets.
Thank you all. Really good ad lib there on the conversation. I appreciate it. One of the areas we've talked a little bit about is the uninsured rate. We've talked about affordability. We've talked about kind of helping get more people into care. And that really leads us into a conversation about Medicaid expansion. We know that 41 out of the 50 states, along with DC, have expanded Medicaid, but not everyone has. And it's been a complicated part of the law all the way along, and just trying to make all of this work. So Ellen, I know you had to deal with this on the ground in reality when you were in Virginia and trying to make this work and become a new part of the Medicaid landscape. So can you kind of share your experience with that and the good and the bad of making that kind of work within the system that we have?
Yeah, sure. And, I very much had the privilege of implementing Medicaid expansion in Virginia. Virginia was a late kind of expansion state, didn't expand until 2019. And, I think the reality is, right, one of the things that, the Affordable Care Act kind of passed Medicaid expansion across all 50 states plus DC. We had a Supreme Court case that essentially gave that choice to states. And you have a population of individuals for whom even with tax credits, even with some of the kind of affordability improvements in the law, just without kind of Medicaid cannot you can't conceive of them affording coverage, right? But folks are going to get care regardless of whether they have coverage or not, because this is our health, this is our livelihood, this is how we stay alive and care for our families. And so when I came to Virginia, it passed Medicaid expansion, and just the incredible relief hearing from folks about having that certainty, being able to kind of get that, having the certainty of healthcare, being able to get that job, not having to kind of focus on and getting better, getting more productive, really bringing that peace of mind to folks was incredibly important. And I think Virginia first estimated 400,000 people would get coverage. It's now I think 600,000 folks today. So it's just such an incredible lifeline, both in a mental lifeline, but also a physical lifeline to folks across the states in Medicaid expansion. I'll say a couple more things. One thing about Medicaid expansion and the ACA itself is that, it attempted to create a coverage continuum, right? And so if you're Medicaid eligible and you get that new job, that's great. Maybe that job doesn't provide insurance. You can go up to the ACA marketplaces to really provide that certainty that I think Andy mentioned earlier, kind of job lock, that no matter where your life is taking you, you can have the assurance of insurance. And that's truly incredible to hear from people. The other benefit I'll say about kind of Medicaid expansion is, oh boy, am I so happy that Virginia was a Medicaid expansion state when COVID hit. I think the absolute kind of certainty that folks had coverage, incredibly invaluable, not only for people across the state, but if you look at Congress, the Congress is able to use the Affordable Care Act as a base to build those kind of COVID protections atop it, right? So continuous coverage in Medicaid, enhanced premium tax credits on the marketplace. Just really so thankful that underlying structure was there, so that we could, so the insurance structure could provide that kind of necessary public health response to the crisis.
I would agree with you. Having, taken over a Medicaid plan during the middle of the pandemic and actually kind of being in two different companies while doing it, there were so many flexibilities that we had because we could keep people on coverage, we could manage the structure, we could waive some of the things that we would have otherwise done, and just then we could push on vaccinations, we could push on hospital care that needed to really happen, and people weren't worried if they got COVID, what would happen to them. So I think it was a very helpful thing for us to just live through the complexities of the pandemic, and then on the vaccination side to really drive that through a good public health type structure. One of the things that's kind of happened since all of that is now we've got the One Big Beautiful Bill Act, or HR1. It has a lot of names and a lot of acronyms. So, that's really addressed a lot of the focus on the childless adult population, on that Medicaid expansion group. So, Randy, I'd like you to speak a little bit just on perspectives on how that bill has now kind of pushed the approach a little bit different direction on work requirements, on redetermination schedules, on kind of just the nature of how we support that population in healthcare overall.
Yeah, well, I mean, first thing is I will admit I'm not a Medicaid expert. I do come at that mostly from the individual market perspective. But so, my view on a lot of this is, even if you think back before the bill, you still had a number of states that had not expanded, Medicaid. And, I wish there had been, more of an openness really with both parties to a partial, expansion. Obviously you got people in a lot of states from 100 to 138% of federal poverty who were in the exchanges, and in some of those states really formed the backbone of the market. And so if there had been some more flexibility, I think to get folks in the coverage gap, below 100%, for example, I think you might have had more take up of that. And I think a little bit of that maybe frustration or of the inflexibility is reflected in the legislation, sort of with the enhanced match for this population that in many states is, on the exchanges, and getting coverage, and, what are the sort of equities there. So I think you saw that reflected in the legislation. And then, obviously another huge topic is program integrity, and, coming out of the pandemic, coming out of the enhanced subsidies and the unwinding all that, I think there was a lot of concern, among members of Congress about, people who are duly enrolled, or there are situations where people aren't being verified, or they have other coverage. And so, I think that was a big focus. The work requirements, that's been around for years, right? In the sort of, Republican Medicaid reform circles, I see it as, probably more a program that is going to sort of work around the edges. I don't necessarily see it as probably most people who've heard, talk about it. It's not necessarily going to move the needle a ton, but it's just that concept of, maybe private coverage, or maybe, some sort of, welfare to work, or whatever you want to call it, is the best way to address that population, especially, you look at the expansion population, and then even right below that, with some folks who are working, most of them are working, right? So give them some upward mobility, I think was the goal.
No, I can definitely see that. And as we know, so much of the Medicaid population is working or can't work. The group on the childless adult side will probably be small, but it's still impactful and something we'll have to manage our way through. Andy, any other reflections on that question? Just to make sure we give you a chance to jump in as well.
Sure. I mean, I think we just have to acknowledge $1 trillion taken out of healthcare for the lowest income Americans is going to have consequences. And it's going to be really difficult for states to manage that scale of impact, either work requirements or the changes to provider taxes. Like, maybe states could adjust, but both on top of each other, coming pretty fast is going to overwhelm a lot of states, and we're going to see real impacts on coverage, because of paperwork burdens, because of the choices states are going to have to make. And what, is concerning too is, even if control of Congress moves back, that scope of money that would have to come in to fix it. I was talking to a pretty senior staffer last week about it. Like, how do you make that up? So there's talk about, kind of alleviating, smoothing around the edges on some of that, but there's real financial issues that you would need to work through in order to, kind of smooth this out. So I think I do have real concerns that things are going to get worse before they get better, and we're going to see, a real movement in the wrong direction on coverage that's counter to what we've seen kind of for a generation, is this expansion of coverage in a steady way. And we're going to see a serious backslide going into the next presidential cycle. And so while healthcare, I know we've experienced this, Randy and Alan and David for sure, healthcare being a central political issue, we saw that kind of dissipate, and I think it's back on the upswing, and I think that, that's problematic. And I think it's going to create an appetite for some significant reforms.
I think that's a very astute observation. One question I'll toss out to all of you is, we haven't talked much about the delivery system on the healthcare side of the providers, the hospital systems, the doctors, nurses, and such. And there is a lot of concern that's been raised as part of the HR1 passage, and just the impact on those areas, given how much of their population is Medicaid or childless adult dependent. What are your thoughts on just the nature of that system, the delivery system, especially in the rural areas, as rural hospitals are already stressed and challenged? And how do we, make sure that wherever you live, you have access to the care that you need?
I'll start, which I'll just kind of pull from something that Andy just talked about. And I think that providers are going to will experience firsthand, right? Along with their patient, is that, we see thematically in HR1 and some of the regulations that have come out recently, that there's been this move toward more and more paperwork, right? In work requirements, in verifications, and the like. And I will tell you that the last thing people want is more nuisances and annoyances when you just are trying to get healthcare. To get insurance in the first place is incredibly hard, and then to get care in the second place is incredibly hard. And we're moving in the backward direction there. And to that kind of provider question here, so much of what happens is that individuals will or can lose their health insurance, and the first time they find out about it is when they go to the doctor or they go to the pharmacy and the like, and particularly in places that serve primarily low income populations. A lot of expectations are placed on these providers to kind of help people get back into coverage. That's very difficult and not really in the budgets there. And so I think that, not only we have kind of the kind of dollar cuts, but we will also have kind of the degradation of experience that I am particularly worried about with patients and providers, as the kind of churn of coverage is I think, dramatically increased for a reason that is difficult to think about. As you mentioned, most people are, on Medicaid, if we're talking about work requirements, most people are either working or can't physically unable to work. And so it just kind of question the rationale there. Like, it is putting more frustrations into the healthcare system is a really difficult place to be in. And I think gets back to it's going to become a lot more political as we go into the next presidential cycle.
I would definitely agree with that. Randy, you came off mute. What are your thoughts?
Yeah, I mean, so, I think, Andy, we brought up at the beginning about the cost of healthcare, and we still have to do something about that, right? We have not really addressed that as a country. We haven't, honestly, doesn't seem like we can have an honest conversation about it, really. And that's unfortunate, but then we deal with all these other attendant problems, right, that come out of it. And And so, I mean, we're talking about pulling money out of the system. I mean, we put, hundreds of billions of new dollars into the system, coming out of the pandemic. And then, we say, okay, we're going to try to save money. We're going to try to lower costs. I don't think we're pulling the right levers. I don't think we're looking at the right things. And I would just say, I think, Ellen, to your point about verifications and things like that, I mean, I totally get that it is a pain for people, but I think we have to figure out a way to do it in a way that's not a pain for people, because, I do think the dollars that we're spending, as taxpayers and as a country, and that's the way the law is set up, right? You need to be verified if you're in basically the ACA. If you're eligible for some other program, you're not eligible for premium tax credits, right? I mean, that's in the law, right? So, how do we figure out a way to make sure that that's the case, and make sure that there's not, enrollment and inappropriate enrollment, but in a way that is hopefully seamless for people and does not put them, put an excessive burden on them. So, but I think the biggest thing to me is, we've got to do something about healthcare costs in this country. Coverage, we've largely, I think we've done a lot as a country to address that. We got to get to the cost issue.
Totally agree.
Thank you all. I appreciate that. I think the cost piece has been a really big part of the conversation, especially as we look at tax credits expiring and tax credits not being renewed, and trying to figure out how to deal with both the considerable increases in the rates, as well as how to make that affordable and viable. We all know that gets driven heavily by the increase in healthcare cost, but it's also just a nature of the marketplace of trying to meet our expectations for our regulators, as well as the appropriate rates to make sure we're properly funded and managing all of that. So we know that we're seeing a lot happen with that tax credit expiration that occurred at the end of the year, and the impact that is going on with healthcare. So Randy, why don't we start off with you of just how are you seeing some of those costs get attacked? How are you seeing the affordability get addressed, both on the delivery system side of trying to find ways to make healthcare more affordable, as well as trying to make the premiums and the benefits and everything something that can be viable for people?
Yeah, I mean, I think it's a great question. I think, obviously the premium tax credits, the enhanced ones, just expired. And so we're sort of figuring out what happened, with the last open enrollment period, with plan selections, new people coming into the market. So, I mean, premium tax credits, or, credits for people to purchase coverage, is not getting, at the affordability issue, other than, at the tail end, right? It's not addressing, what's going on with the provider side of things, which I think is the much bigger picture. So how do we drive providers to lower their costs, to be responsive? And one of the rules I worked on in the first Trump administration that is now going through revisions is the transparency and coverage regulation, which as imperfect as it is, and as difficult as it's been, I think, for many issuers and others to implement, is an honest attempt to sort of say, okay, let's get the prices out there. People are paying the costs out of pocket, whether they be employer coverage or in the individual market. There, a lot of them have high out-of-pocket costs. Give them the information they need to be able to make as informed a choice as they can, as they're faced with shopping for care. So I think that's one way that I think there are, again, earnest attempts on both sides to try to get at the cost issue. But are we there yet? I think not at all. We're not there yet. We have to do a lot more. I think you're on mute.
I am. My apologies. There's a little bit of background noise here. Fully agree with you about the need to do a lot more on that side. One factor in kind of looking at that, it isn't just the individual market that's facing those cost and rate challenges. We also see it heavily in the commercial group markets and the employer markets, and all pretty much across the board. One of the things that's come up it was brought about in the first Trump administration was ICRAs, individual coverage for health reimbursement arrangements, and those components of that. So I'd like to ask the panel, how do you see that fitting in? Because it drives the group world into the individual world. It changes the dynamics. It changes the responsibility of the public funding model to handle all of those pieces. Andy, maybe I'll start with you and just kind of talk a little bit about that perspective of how you're seeing that develop in your market and kind of what you think that might mean going forward.
Yeah, I think ICRAs are an interesting option, and we've heard a lot more about this. I'd say I think it tends to be state specific and how your it's pretty micro wonky, but your small group rates and your small employer rates and your individual rates match up. And so in California, it just doesn't make sense because our small group rates are cheaper than our individual rates, and so there's no need to push people through. But I think, as to your point, Mike, like we see costs for employers continue to be a challenge. I think they're increasingly going to look for options where they can provide some kind of benefit to their employees, but let them go pick the plan that works for them. If it's a higher deductible plan for lower premiums or more comprehensive plan for higher premiums, they may kind of go that way. But again, I guess like in violent agreement with Randy, that none of this really addresses the core issue of costs. And we just tell a story about somebody that we talked to in California on the extension of the tax credits. So he's a architect, he used to started his own business, was at a firm making about $200,000 a year in California. So he's doing fine, pretty well, and has 2 college-age daughters. So he's got that time of his life where he's got a lot to spend on. He's supporting them in school, which is not cheap, as we all know. So his premiums on a Blue Shield PPO plan in Southern California were $1,500 a year with the tax credit. So not cheap, but manageable for him. When the tax credits went away, his coverage became $4,500 a year. So nearly $50,000, so a quarter of his income, to go to healthcare. So he can't afford that with his kids in school. So he decided to drop his own coverage and insure his daughter and his daughters and his wife. He's 60 years old, done everything right, exercises, good health. And so now he's kind of just trying to stay safe until he can age into Medicare. And it just strikes me like that's not a system that's working for people. But it illustrates 2 points. Number one, like without the tax credits, healthcare is unaffordable, and we shouldn't have premiums that are over $40,000 a year for a person. So we have to deal with that cost. And we've got to there's an urgency here that I think we need to feel on behalf of the people like Mark to tackle both of those. So I think we need to acknowledge healthcare is too expensive. We're going to have to do things to help people afford it, and we really need to get serious about the cost of coverage in this country across all markets and start to really do something about that.
Thank you, Andy. Ellen, I'll give you a chance to weigh in as well.
Sure, I'll say a couple of things. I mean, I think we find one certainly one area where we can all agree is that the kind of price affordability is or inaffordability really here is unsustainable, and you cannot tackle you can't just tackle the problem by I think people used to say, right, if get everybody in the system, right, and then we can figure it out, or it'll figure itself out because there won't be distorted costs from uncompensated care. We now know that that's it's not going to figure itself out, right? We got almost everybody in, and it hasn't figured itself out. And so, I think, to Randy's point, I've never really been like a big, transparency will save us all person, and I'm still not. But I do think it really speaks to kind of this fundamental question that people are asking, which is like, why? Like, why is it so expensive? What is in here? What is baked in here? And so I think it's not only the kind of prices themselves, but just figuring out like what are the component parts of that. And as a society, is that actually where we place our value, and what do we think of that kind of price makeup? And so I think, and I think a lot to be done there. And I think both, Democrats and Republicans alike are at that table, where we're kind of all nodding and saying, no, 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 there is a fundamental problem here. And I think employers as well. On the on the ICRA pieces, like Randy and I both ran the individual market. We are big proponents of it, right? I think we both, I mean, Randy, I don't want to speak for you because you haven't spoken on ICRAs yet, but like, the getting more people into the individual market is very much a goal of mine. Because there are consumer protections in the market. These are Affordable Care Act plans. They carry with them important protections. It's a price sensitive market. I think that is useful for people to kind of go into and figure out what piece works for them. Now, it has to be affordable in the first place. And I think that's bringing it back to the question on the enhanced premium tax credits. You want an individual insurance market that can compete, right, with the small group market, that does look attractive to employers, that employers can feel good about sending their employees to. And I do think with the expiration of the enhanced premium tax credits and some of these pieces, like the end of auto renewal in HR 1 that kind of degrade that underlying single risk pool, I worry about that kind of affordability proposition for an employer looking at the individual market and then saying like, I don't know about that right now. And so I'd like to get to a place where, we've got millions and millions and millions and millions more folks coming into the individual market, but we have to have an affordable one and a stable one to start there.
I agree wholeheartedly with you, Ellen. Randy, I'll let you jump in and see if you have anything else you'd like to add as well.
Yeah, just on ICRA, yeah, because that was another rule I worked on a lot, in the first Trump administration, and yeah, the idea in an ideal world, I think you would have, lots of employees coming over from the group side, especially the small employers or even the sort of mid-sized, large employers, 500 lives, something like that, where they're looking for, an easier way to provide coverage, or they don't want it. The employer doesn't want to have to stay in the game of trying to pick everything, for their employee. They're looking for something administratively simpler. And then, but it is only as attractive, and it only works, to the extent that the individual market is attractive itself. So there's a chicken and egg thing that goes on there. I mean, the only thing I would say to that is, I think an ideal, thing in my mind, and this was actually the way it was initially projected by CBO, would be a market where it's like half subsidized and half unsubsidized, right? So I think that would be the ideal, where you have a big enough market and risk pool to where you have those signals from the consumers who are unsubsidized, about what they want to see with benefits, what they want to see with premiums, out-of-pocket costs, putting that pressure on the rest of the market to keep those people happy. I mean, I think it's possible. I know it's difficult, but ultimately, I think that was sort of the virtuous cycle that Ellen, our good friend Jeff Wu, always talk about the virtuous cycle, where you have all of these different preferences being expressed, to make the market better and to make it sort of meet all the disparate needs of the people that come to the market.
Thank you. I'm very curious to see how this starts to evolve, as Andy, your description in California about it not really making sense, but I see a lot of states in the East Coast where the group and individual rates are very much misaligned, and the differences are big. And at some point, I can't imagine being a broker walking into an employer group and saying, here's your 35% rate increase again, and them not saying, and here's the way we might be able to do this differently. I think the economics are going to become a challenge for many employers just trying to figure out how to make this work. So one thing I wanted to hit really quickly, and we'll do this one a little bit faster, is just on fraud, waste, and abuse. We talked a lot about affordability. We talked a lot about the cost and making this viable. So Randy, why don't we start with you on just quick thoughts on the world of fraud, waste, and abuse in the system, and how the bills and the ACA and HR1 kind of helped or haven't helped address that.
Yeah, it's a great question. I mean, it's been a huge focus of the first year of the Trump administration, and obviously with the bill passing. So I have to say, going back a couple of years, I was alarmed at seeing hearing some of the allegations of fraud or some of the sort of signs going on, and so definitely really concerned about that. And obviously we have to try to do something about it. I think, I think whatever we do about fraud, we have to make sure that, kind of, we talked about it before, Ellen, that people are still able to enroll, that it's not excessively burdensome for people who are eligible and who are, not trying to commit fraud, or they're not trying to get improperly enrolled. But yeah, I mean, I genuinely support trying to get a handle on it, trying to make sure that only people who are eligible, are able to enroll and get the premium tax credits. I do think there's some, in the statute now, there are going to be some pretty big potential shocks if a lot of communication isn't done and if it's not done fast. So for example, on the recapture of the excess premium tax credits, that is in place now, right? So 2026 coverage, if when it comes to tax time next, a year from now in April, people are going to have to repay 100% of the excess premium tax credits that they receive. I don't know if anybody's really talking about that, right? And I'm just really worried. And decisions have to be made now. People need to be going in and updating their income information, as it changes during the year, to make sure that they're not in a position where they have to potentially pay back thousands of dollars, in premium tax credits at tax time. So that's one example of, I think, it's good to have program integrity, but I think we have to be smart in how we implement it. We have to be sure we communicate to the consumer, and we have to make sure that we're doing things in a way that is not overly burdensome to the people who are really just trying to get coverage.
Thank you. That's a really good call out. Ellen, thoughts from your end?
Yeah, I mean, I think, to Randy's point, and I'll make it my own, which is, you want to have a, Medicaid, Marketplace, Medicare, car insurance. I mean, you name a market, right? You want to kind of prevent fraud and go after fraud by going after fraudsters, right? You don't want to, right, harm eligible folks that are just trying to get enrolled. And so it is about striking kind of that right balance, and really, going for policies that are precise, right? That are precisely going after fraud, and not ones that really do have these kind of disproportionate impacts on individuals who are eligible and trying to get enrolled. And I would just say, like, underlying to all of that continues to be, a system of coverage that does continue to have coverage gaps, discontinuous eligibility in places that haven't expanded Medicaid, some of these distortions in the market that shouldn't exist. And when you smooth out, when you're kind of able to kind of smooth out these eligibility distortions, I think you actually can, prevent and disincentivize fraud in many cases. So I think it's not only looking at, kind of placing additional kind of rules on folks to get coverage. It's actually looking at kind of some of these underlying coverage discontinuities that are present in the market, and really and really kind of foil pretty desperate people. They're trying to just get coverage.
Thank you, Ellen. Andy, any thoughts from your side?
I'll just go back to, I think Randy and Ellen are public servants in the best sense of the word, and I think both of them, I completely agree. We need to address fraud, but we don't want to prevent barriers from people who are eligible for coverage from getting it. And I think we all share concerns that we may be headed in that direction.
I would agree with that. So we have just 5 minutes left, so I'm going to ask a fun question. So I give you your CMS policy magic wand that you can change whatever it is you'd like to change and make it a reality. And you can have whatever impact on the system you'd like to have. So I will start off with Ellen. What would you do?
Well, Mike, I'm gonna make it my magic Congress wand.
That works too.
Instead of my magic CMS wand. But I was just talking about, and this is something that I'm incredibly passionate about. I spent a lot of time at CSIO kind of working on and pushing on is kind of these kind of discontinuities and frictions in care and in coverage across programs, across, Medicaid, Marketplace, Medicare. And so, if I had my magic wand, I like everybody is eligible for something. Like we'll deal with coverage gap, and we have now many lawfully present immigrants are no longer eligible for things. But the vast majority of people are eligible for something. Why does it have to be so hard to get it in the first place? And so I would really like, my number one thing is rationalizing kind of eligibility rules across these programs so people can actually move seamless across coverage, which improves care, makes people so much less frustrated with government, which is great, and really kind of improves kind of lives for everyone involved in the system. So that's my number one.
Thank you, Ellen. I think that's a great one. Andy, I'll go to you.
I don't think we have enough time for my magic wand, but I'll build up Ellen. I think she's right on. And taught a few classes, and you try to like explain to students the difference between ACA, Medicaid, the employer market, different sectors in there, self-insured, fully insured, Medicare Advantage, and every one of them has different eligibility rules. Every one of them pays providers differently. Every one of them has their own challenges. And that I think it makes it so that, we're fighting about the ACA when we need to talk about the broader market. We've kind of picked off Medicaid and the one big beautiful bill. That's the poorest. Like, why are we doing that to address affordability more broad? We're not addressing affordability more broadly. So I think if I really had a magic wand, it would be, let's get it all into one system and have a conversation about that instead of these kind of one-off conversations that never really resolve the bigger problems we have as a country.
Thank you, Andy. Also, alignment there. Randy, anything else to add on?
Yeah, it's hard to give a magic wand to an incrementalist, right? That's like really tough. But so, I guess I'll just say, as in my incremental brain, I will say, give states flexibility to experiment. I think we have not cracked the code on coverage, on affordability, and I would add, consumer empowerment as a big piece. So let's give states the ability to, as a laboratories of democracy, to do that and try to improve and try to come up with, that's how the ACA was really born, was through state innovation, right? So what's the next state innovation? And so that would be my magic wand tool.
Thank you. I think it's a good approach as well. All right, so we promised Andy we get him out of here on time to catch his flight. So I want to thank you all very much for participating. Ellen, Andy, and Randy, thank you much for your experience, your insight, and your views on the market and working through all the questions with me. I want to thank you all for listening in on this call as well. And I hope you found the insight as useful and valuable as I did. I wish you all a great day, and hopefully we get to celebrate much more of the ACA going forward.
Thank you.
Thank you.
Thank you.